ask questions. Thanks, Fiona. So we're going to kick off with a presentation from Dr. Claire Brockbank. As everyone knows, this session is all about Botswana, and CGHP has a really long-standing partnership with Botswana, and we've known Claire for a good long time. So Claire's a GP with a special interest in diabetes, and she's going to be giving us an overview of her experiences, both in the UK, but also Botswana. So Claire, if you're happy, I'm going to hand over to you.
Thank you very much, and thank you everyone for welcoming me this evening. So my name's Claire Brockbank. I'm a UK trained GP, and I trained in London and then worked in and around the Epping and Essex area before moving to Botswana about 10 years ago. And I then started working here. So I'm now a GP here in Botswana. So I thought I'd share with you a little bit about the similarities, the differences, some of the challenges, and then maybe we can brainstorm as to how some of those might be resolved, or some ideas how partnerships could develop. So I will try and share my screen now, which despite a whole year of, or 2 years of COVID doing this, I still worry that I don't click the right button. So if it's not moving, please please wave your hands or say something. So this is really just my own personal experience about primary healthcare in Botswana, and I very much welcome any questions or comments about it. So hopefully the slide has moved on. So just in case nobody knows where Botswana is in southern Africa, and it's a landlocked country surrounded by South Africa, Namibia, Zimbabwe and Zambia. It's a semi-arid or desert country. We're in our nice rainy hot season at the moment. We've had really good rain, so everybody is happy. The Botswana is about the size of France or the size of the state of Texas, and the population is around 2.3 million people. There are quite a large number of undocumented migrants in Botswana, an estimate of about 300,000 who need HIV care. So that number is quite fluid, and we don't really have the exact data from that. Most of those are economic migrants from Zimbabwe, but also some coming up from South Africa. So I just wanted to share with you the map of Botswana and really how that affects the accessibility of healthcare. So this huge country is very sparsely populated, but the majority of the population live in Gaborone, which is at the bottom right-hand or the southeastern corner of the country. And that's the capital city with about 350,000 people living here, but quite a lot more commuting in from the bigger villages around that. And this population sits all the way up that very far right-hand side to the second city in Francistown. So most of the population is huddled along that southern Botswana, South African border. The third city is Maun, which is the tourism destination, which you can see at the top right next to the Okavango Delta, which is the blue speckled bit on the left, and the Mahadehati salt pans, which is on the right. So the roads are those red bits that you can see, and in between is mostly desert or bush, so not very accessible should you live in those areas. On the left is the map of the locations of the hospitals scattered around Botswana, with the colours indicating whether they're the green primary hospitals, the district hospitals, and then the referral hospitals based in the three main areas. And then with COVID, we've now opened the teaching hospital, and that's really at the moment only been used for COVID, but hopefully will become a specialist hospital. And again, you can see these clinics very much match where the roads are on the map. The very top northwestern part of the country is the poorest part of Botswana and has very, very limited access to many of the healthcare services. In addition to these hospitals, there are several different clinics that exist. So there are mobile clinics trying to reach the rural areas, health posts, which are situated in smaller villages, run mostly by nurses. There are clinics that have doctors and are able to perform basic surgeries such as appendectomy and bowel obstruction, and then clinics with that facility and maternity, so they're open 24 hours. So this is the picture of the Ministry of Health. So the health system in Botswana is quite similar to the UK in that it's a government-funded public health system and spending about 5.8% of the GDP in comparison to 8% that the UK and South Africa spend, and Germany spends about 12%. It's overseen by the Ministry of Health and Wellness, and it provides free or very, very cheap care for citizens. It costs about 30 pence to be seen in a hospital clinic as a citizen, and about 50 to 75p for a non-citizen. So anyone can access the health service, but if you're not a citizen, so like myself, I would have to pay for care when I needed it, but it's at quite a reduced cost. If the facilities are not available within the government system, then they will help you be seen in the private sector, and that may include transferring to South Africa where there's more specialist care. There's also quite an informal system related to traditional healers, and the traditional practitioners are registered, and many people use both the traditional and Western style of medicine, and they move between the two quite freely. So you have to remember to ask about that when you're seeing patients. Sitting a little bit outside the public system, but people can access these hospitals in exactly the same way that they would the ones we've just seen on the map, are hospitals that are funded by organisations. So mining is a very, very big source of income in Botswana: diamonds, coal, copper, and most of those mining towns have their own hospitals, and they pay for the staff and often fund training of the doctors and the nurses. Mission hospitals, again, have been set up probably for more than 100 years and have again been run mostly by missionaries. There's quite a large number of NGOs, mostly related to HIV care. And again, access to all of these hospitals is in the same way you would access the normal government system. Since the 1990s, there have been private medical aid schemes. And the history of this really is related to the HIV pandemic in trying to help spread the cost of care for very expensive medication when HIV treatment was first available. So one of the biggest schemes is something called BPOMAS, which is the Public Officers Medical Scheme. And all government employees are able to access that scheme, and the employer will pay 50%, and the employee will pay the other 50% of the contributions. So for example, a family of 5 like myself, our medical aid cost is about 3,000 pula a month, and the employer will pay half of that and you'll pay the other half. So it's about £200 a month, just to get an idea of how much it costs to have private medical aid. And government employees are about 500,000 people, and some of the other medical aid schemes have about 100,000 people in them each. So quite a significant number of the population have private medical aid, which is very different to the UK. So the private sector is certainly much bigger and has a much broader reach than you would see in the UK. So the government clinics, waiting, that is a very common theme to many of the government clinics. Most of the clinics do not run on appointment system. You get up and you go in the morning of the day. You might have been given a slot, but there's no time slot. Most people arrive at the clinic somewhere between 4 and 6 a.m, ready for the clinic to open at 7, and then they just sit and wait until they are seen, which may take most of the day. After COVID, most of the waiting has moved outside, and this is taken in winter, and you can see it's pretty cold early in the morning. So that's one of the biggest drawbacks with the government system. The other challenge is, how do you access care in rural areas? So all of these photographs are taken from that top northwestern part of the country, and the bottom left-hand picture is the main road that goes from near Hunzi up to Namibia. So this is used by trucks, buses, cars, donkey carts, and the road is really terrible, and it takes about 5.5 hours to do 200 kilometers. So it's not easy, and massive potholes, so not very kind on your car. The Gomari Primary Hospital has surgical care, but often very poor access to medication. So the central medical stores in Gaborone has to distribute the drugs through this system of moving to the hospital first and then moves on to the clinic. So it takes quite a long time for drugs to arrive, and often they're out of stock. Many of the roads are like that top middle one, so what's called a two-spur. So in the rainy season, that's often difficult to access, and in the dry season, the sand is often difficult. People use mokoros in the delta, and that's the quickest way of getting from one side of the river to the other. They have just finished building a very beautiful bridge, so we'll see if that helps. Helicopter is another quite expensive way to access rural areas, and there's an organisation called Airborne Lifeline that's funded by PEPFAR that has provided transport for doctors to go to rural clinics to help provide HIV and now care for non-communicable diseases, and recently has been used for vaccinating those rural clinics. So helicopter is quite a useful tool in those very rural areas. And the bottom right hand picture, that is an ambulance that is finished for the day, and as it's just about to turn down the road, is now loading itself up with all the people who are not wanting to wait for a bus, so they're all just piling into the ambulance at the end of the shift for transport, with or without their chicken that is following behind. So yeah, access to the rural clinics is quite challenging, related to infrastructure, transport, cell phone coverage, availability of power, water. All of those things often impact on ability to access good healthcare. Then compare that with some of the private hospitals and clinic. Most of the private care is centered around the Gaborone area, with some private clinics in Francistown and in Maun. But outside of those centers, there's very, very little access to private healthcare, even if you have medical aid. So the pros of that are ability to choose the doctor you want to see, choose whatever hospital you want to go to. We have access to a wider range of medication. The main limitation on that is cost. You have to pay the actual drug cost. So in the NHS, if you have to pay prescription charge, of course you pay your, I'm not sure what it is now, £8, £9, £10 per item, irrespective of what the actual drug cost is. Whereas we pay the actual true cost of the drug. So for example, one insulin pen is 200 pula, which is about £18. So if you need 5 pens, that's quite a big chunk of your salary if you're getting it privately. We have quite fast access to investigations. So blood tests I've done this afternoon, I will get most of those back tomorrow morning. It's very easy to order x-rays, ultrasound, CT scans, MRI scans. So very different from UK primary care, where we're quite restricted in those guidelines as to how we can access care. There are good and bad things about that, of course. You're a little bit more autonomous, so you can develop new services. So I set up a one-stop shop diabetes clinic in the clinic, involving the dietitian, the dentist, foot care, the optometrist, counsellor, so we can do all of that in one go. It's just about working with others. We do quite a lot of charitable work in our clinic, mostly related to mothers, to help prevent mother-to-child transmission. What else can we do? Also, the cons of that, or the downside of that, mostly is financial. So when you go to see the doctor, your medical aid will cover the bulk of your payment. So again, it's about 250 pula, so just under £20 to be seen by a GP. And your medical aid will cover about 200 pula of that, leaving you 50 pula, about £3 short. That's just to see the doctor. Now, if you want to do blood tests, x-ray, ultrasound, any medication, all of that is subject to the same restrictions, 10% co-payment plus the 12%, or it's 14% now VAT. So there's quite a lot of out-of-pocket expense at the point of care, which is very different from the NHS. And we see monthly variation depending on when people have been paid. So payday was last week. This week is busy in the clinic. Next week will be a little bit busy, and then people have run out of money. You wait again until you're paid. So we ration our access to care because of our cash. The other problem is lack of coordinated care. People can move all over, and we don't have a centralized medical record system like you would in the UK. If you lose your job, you have about 2 or 3 months remaining on your medical aid, and then it finishes. So the time of your greatest need, you're very likely to be unable to access your private healthcare. So that's all good reasons to keep the NHS. So what are the differences that I might see in my clinical work in the UK compared to Botswana? So I had a diabetes clinic once a day in the UK, and that was really based around medication reviews, discussion of blood test results. Whereas here I find myself doing insulin initiation quite regularly. We see people in DKA. We have 4 very, very excellent nurses who are able to do a lot of procedures, and we have 5 beds that we can, sort of daycare beds that we can put people in. So we often manage DKA in the clinic, and if they're well enough, they go home and they come back the next morning. So that's, again, not something you would normally do in a primary care setting in the UK. Contraception and antenatal care, I do a lot of implants, IUD fittings, all the usual things. We have access to those. And in addition to that, in Botswana, I do a lot of antenatal ultrasounds, particularly for our non-citizen undocumented migrants who do not access government care very easily due to their lack of paperwork. So we tend to see them on a monthly basis. Chronic conditions, of course, they're the same around the world: blood pressure, asthma, arthritis and obesity, a bit more of an issue in the UK. Chronic conditions here, my biggest challenge was suddenly having to learn all about HIV. And again, as a GP in the UK, that's something you really do not see. Most HIV positive patients have been managed for the last 30 years in secondary care and sexual health clinics. And there is a move to try and change that in the UK and move people into primary care for their HIV. So HIV, diabetes and blood pressure are probably my top 3 chronic conditions. Care of the elderly has a huge workload in the UK, and dementia, falls and polypharmacy, and really we don't see very much of that. We have a very small elderly population here. Less than 5% are over the age of 60, and part of that is related to the decimation of the population during HIV at its height in the 80s, 90s and the early 2000s. So many people my age and up to 20 years older died, so they're not here. We have about 70,000 HIV orphans from that time. The other thing we manage a lot of is septicemia, so meningitis, and very, very ill HIV patients who come sick with TB and sepsis. They often have 5 days of IV antibiotics and fluids to sort of resuscitate them. We use our ultrasound to diagnose pericardial TB. What else? Abscess drainage, malaria. Of course, mental health is the same in all countries, huge mental health issues. Socially here, mental health is not very well talked about. There's still a lot of stigma related to that. So people often do not access care, sadly. And our cancer work is again slightly different. So a large amount of cervical cancer, particularly in our HIV positive women, and large amounts of women presenting with very late breast cancer. So a slightly different cancer picture to what you would see in the UK. So what are some of the health successes in Botswana? So really the HIV care is a huge success for Botswana health system. So the first case was found in 1985, and they started the rollout of highly active antiretroviral therapy in 2002 at a time when the drug regimes were quite complicated and extremely expensive. And that's what really drove some of that private medical care in the 90s to start providing HIV care privately. Botswana at that time had the highest incidence of HIV, affecting 40% of adults. We're now sitting at around 20% positivity rate of adults. A lot of private public partnerships sprung up at that time to help roll out huge amounts of care that was needed across the country, and doctors from Cuba and America, Canada, UK, huge numbers of doctors came here because we really didn't have manpower to actually manage that manage that huge number of people who needed to be started on treatment and monitored. The Botswana UPenn and Harvard partnerships are still going strong. And in fact, the lab that picked up the Omicron is the lab that was opened in 2002 that has spent 20 years doing gene sequencing for HIV. So actually they're very, very used to doing that viral sequencing. In 2019, there was another big step forward when the government finally allowed access to HIV care for non-citizens. And that really was quite a big game changer. And that was the tipping point to bring mother-to-child transmission to less than 1%, which happened last year. We have very, very good access to childhood immunization and under 5 care. People go monthly to the clinic to weigh their babies. The schools have a great HPV vaccine program since 2015, only for girls at the moment. And then the University of Botswana Medical School opened in 2009. So what are some of the challenges? So some of the biggest challenges we had are access to reliable medication. Things go out of stock. Suppliers just stop supplying. For example, we have had no MMR vaccine for nearly 3 years. The supplier has pulled out of Southern Africa and you cannot get it. So now you're onto single measles or measles rubella vaccine. During COVID, that's got a little bit worse. We had lack of access to some of our HIV treatment, and that has caused some issues now with viral failure and people defaulting care. We've seen TB that has been missed and HIV that has not been started on treatment promptly. We have a very high maternal mortality rate in Botswana, despite quite large amounts of money spent on the care, and they are attempting some things to try and make that a bit better. We do not have a good centralized medical note system, so continuity of care is challenging. In the government system, people carry around A4 cards that they have their own handheld records. We have geographical challenges, as we've seen, with rural areas, huge rates of road traffic collisions, one of the highest in the world, and driving at night have a high risk of hitting donkeys and elephants and cows. Drink driving is a massive problem. So road traffic accidents in Botswana have one of the highest mortality rates. We have rapidly expanding numbers of junior doctors. This is to do with the medical school. So when I started teaching there, we had about 60 in a year group, and now this year's intake is 90. So large numbers of doctors, but we do not have a proper postgraduate training program for all these doctors to drop into, or formal mentorship schemes. So there's big issues with staff retention, career pathways, and people get rotated around. And Evelyn might tell you about that with one of their eye nurses. They get sort of picked up from their specialist job and dropped somewhere else. So how do you retain skills in certain areas? So these are some of the challenges. So the horse picture is challenging because you have to go through that water with no saddle with crocodiles and hippos. So that was my challenge. So about partnerships. So as Evelyn said, we have had a connection with the East of England partnership and with Cambridge Global Health starting in 2019. We had a group of teenagers with type 1 diabetes come out to visit us and join our residential youth camp with quite a number of healthcare workers that did some excellent talks and education, both for the children, the parents, and for healthcare workers. So that has worked really well, and we have an ongoing partnership with them. We did a virtual youth camp running for 2 months just before Christmas, and starting next week, we have got a similar 8-week program for healthcare workers. Again, that will be online. So I guess my sense of how do partnerships work, it's really looking at mutual learning. So whether you are from the UK or Europe and you're coming to Botswana, or whether you're from Botswana going to the UK, everybody has something they can learn from that. We can learn from each other. It's not one-way learning. And about how do we share skills? How do we transfer skills from resource-rich countries to under-resourced countries? And how do we develop sustainability so that when we leave a country, the service doesn't collapse? So it's about trying to upskill and broaden healthcare. It's really important to have things within the local context. And I struggled quite a lot with that when I first moved here, that although the disease and the drugs are similar, social contexts and patterns of behavior, living, cultural norms really took quite a long time to understand and to make sense of, and to make my advice for certain people didn't really work so well here. So it's really important to make sure we understand the local context. And one of the thoughts on that is, how do you help facilitate healthcare worker training? So as a UK doctor, you could also learn huge amounts by coming to different countries. There's loads of skills that we don't get the opportunity to develop, and conditions we really don't get to see very often. So we can bring some of our skills here, but we can also learn a lot that we can take back. So how do we facilitate that as part of training programs? So Kaliboha, which is thank you, and you're all welcome to come and visit Botswana. So I hope that's given a little bit of an insight. So please feel free to ask some questions.
Thank you, Claire. That was fantastic. So if we just open up to the floor, really, if anyone has any questions, please just unmute and go ahead, or pop them in the chat box. Claire, I suppose sort of in the interim, while people sort of start mulling over some questions, I just wanted to sort of ask you, I suppose, I've got lots of questions, but, you know, as a healthcare professional who's spent time in the UK and then spent time in Botswana, kind of what's been the biggest takeaway for you, really, having sort of these global health experiences?
I think it just shows that people are interested to learn different things, to see how healthcare is provided in different countries, and to maybe think a little bit out of the box as to how can we bring some skills together. Many challenges we have here is lack of certainly specialist care. If we look at doctors, and that's the same for nurses. So we have quite a large number of nurses, and now getting quite a large number of junior doctors, but how do we help keep them in country, but that they can develop the skills that are needed? Because to go somewhere else for 5 or 10 years is quite difficult. Many doctors don't come back, and that's what has happened not only in Botswana but lots of other countries. People go overseas to train, and then once you've spent 10 years living somewhere else, it's actually quite hard to pack up yourself and your family and come back again. So I think partnerships could bridge that a little bit.
Absolutely. Oh, we've got a couple of questions in the chat, so let's have a look. So Sarah's asked, are there any personal experiences that touched your heart and changed your perspectives?
Oh gosh, okay, that's quite a difficult question. Many, I suppose. Let me try and think of, I suppose there have been some that were quite sad, and some that obviously have had quite good outcomes. I think in my first year of being here, so when I'm still really finding my way around and not so confident in managing very, very sick people, our clinic is a little bit outside of the norm, because the founding doctor has a huge role in starting the HIV care, and we have a very, very big population of non-citizens who use our clinic, and they often come very, very late with sort of end-stage AIDS and TB and meningitis, and come very, very sick. And if we try to send them to the government systems, they're often not helped because they don't have the papers and they're not really meant to be there, so they're not helped. I remember one lady, she had a baby who was probably 6 or 7 months old, and she had TB, and we were treating her, but she wasn't really getting any better, and she had abdominal TB and was really, really ill, and there is a limit to what we can manage to do. So we sent her to hospital, but sadly she died 2 or 3 days later, and that was really quite difficult for me, in knowing that what else could you do, even though we'd already done a lot more beyond our scope of care. So those sorts of things are quite difficult, and I think as a GP in the UK, you don't really see that so much, because there's always somewhere else you can send patients to. It's not that you don't see people get very ill and die, but you're able to send them somewhere else, knowing that they would get good care. Some of the really good things, again, I think related to that group of patients. So really making sure mums start on their HIV treatment, knowing that they're virally suppressed, they have normal deliveries, they breastfeed their babies, and their babies are negative. So that is a really, good thing. So yeah, that's sort of a happy and a sad story.
Thanks, Claire. Sarah, I hope that's answered your question. So I've got another one from Lou, who says, great presentation. What innovations have you seen which you're excited about, and where do you see the greatest scope for impact?
Oh gosh, these are really tough questions.
Meaty questions.
Innovations. Well, I suppose technology. If we look what's happened, I've tried very hard not to talk about COVID, but of course it has affected everything. The really good things about COVID is the huge number of online meetings we can have. Sometimes that's maybe been a little bit too much, but it's really given access to courses, education sessions that most people would really not have been able to attend. So for us here, everywhere is quite far away. It's very expensive. You don't get paid study leave. So actually, it's quite difficult to attend big global conferences and to learn new skills, whereas many journals have now given their access for free. So I think that sort of internet use has really brought things forward a bit more in education. And certainly from patients, again, we have patients who do use our clinic, but they live a 12-hour drive away. So they're not going to come regularly. They might come for their 6-month check, their blood test, do their mammogram, do their pap smear, and then they pick up their medication at their local pharmacy. But it means you can follow them up. We can do WhatsApp calls. We can do, which is probably not terribly secure, but that is a very easy way of us using internet, and that is quite easily available in the country. So I think it has opened up some of the doctor access, which it didn't do before, and some of the family medicine trainees have been able to access us more with questions and kind of video calls. So I think technology is really a huge innovation.
Oh, thank you, Claire. And I'm just going to pose one more because I'm aware we're sort of marching on with time. But so Simon's asked, can you say more about how COVID has affected healthcare and what's being done to counter it?
Yes, COVID. So Botswana was actually very fortunate in 2020. We had a very strict lockdown for 2 months when we had, I think, 2 cases. They shut down the whole country, and our border was shut until January 2021. So nobody was allowed in or out of the country, and the country was divided into zones. So you couldn't travel in and out of the zones without a permit. So my children and my husband did not leave our house for 2 months. You were not allowed out of your premises without a movement permit. So that sort of delayed COVID a lot for us, and we dodged it in 2020, but in 2021 it arrived, and in July it was pretty terrible. We had really no hospital beds at all. There was limited access to oxygen. We have 3 oxygen cylinders in our clinic, and it wasn't possible to refill them because there were strikes and shortages in South Africa. So we rely heavily on South Africa for our supplies. We managed to purchase oxygen concentrators, but our garden in the clinic became an outdoor intensive care unit. So people sitting on chairs or on beds with drips, concentrators, oxygen cylinders, we're able to do things like D-dimers and clotting profiles and give Clexane and steroids and antibiotics. So we manage sort of ICU type COVID in our clinic with people of oxygen of 50 or 60% when they arrived. And then we'd send them home with their oxygen machine and hoped that they made it back in the morning. And thankfully, most of them did. So that was pretty terrible and sort of beyond what you would expect to do as a GP. But of course, many healthcare workers had that. It's also triggered quite a lot of extra diabetes. I've seen quite a large number of people with new diabetes post-COVID, and we have about a 6% diabetes rate here anyway, and that's rapidly increasing. So that's going to be an ongoing challenge. During the lockdown, lots of people did not have access to their medication. So again, if we think of our undocumented migrant population, they did not dare go out because they were roadblocks and army checkpoints. So if you were out without the papers and you didn't have a valid passport, you were deported. So they were not going out. So we have about 500 families. So we would contact them and arrange courier deliveries of medication and groceries to that group of people. So that provided some challenges. And I have seen a small number of people who did not get access to their medication who've now failed their HIV treatment. So I think that in the next year or two is going to be a countrywide problem. The testing machines for viral load were used for COVID. So again, we had to choose whether we were doing COVID tests or the PCRs or your viral load. So that again is a bit of a challenge. And some of the drugs that we use, one abacavir, that was touted to be one of these COVID cures. So abacavir went completely out of stock for nearly 4 months in the country. So where other countries were buying it up to use it when it was not yet proved, that's had a bit of a knock-on effect for us with HIV care. So I think we'll see a lot of missed conditions, and we've certainly seen that over the last 2 months, people coming very late with TB. And of course now, if you have a cough, you must have COVID. Nobody's thinking about TB. And now if you're sweating, well, you might also have malaria. So you have to start thinking of not just COVID.
Thank you, Claire. I'm just going to ask you one final question, because I spotted Judith's put a question in the chat box. So she's first asked, where are you based? And then could you give the name of the clinic and location? And and if the opportunity to make changes in the health system, what's one thing you would change?
Oh my goodness. Okay. So the easy ones first. The clinic is called Independent Surgery, and we're in Gaborone, which is the capital of Botswana. I can share that details if anybody wants. And actually on the slides, it's got the name of the charity, which is called Cover the Globe. So if you click on that link, that will take you to the website that is based for that charity for the mums and the babies. What opportunity would I change? Well, given that I'm a GP, I would strengthen the primary care system and really make the health system a primary care, and try to use it a little bit like the NHS as a gateway to onward care, and try to have more integrated care. So making sure people send referral letters. How can we have a better computerized system to improve our continuity of care? So I think it would be strengthening the primary care system, but I'm a little bit biased on that.
That's allowed. I think Judith says she's also in Gaborone.
Oh, okay. Hello, Judith.
There you go. Fab. Claire, thank you so much. That was just fantastic. And I think, sorry, Claire.
No, I just say thank you very much for inviting me.
No, it's fantastic to have you, and I hope it's okay. But if anyone has any further questions for Claire, please do contact us. And I'm sure, Claire, I'm speaking on your behalf, but I'm sure she'd be happy to answer them, and we could pass them on. So thank you, Claire. So next up, we've got Evelyn Brealey, and Evelyn is Director for CGHP. And Evelyn has spent a significant amount of time in Botswana, so knows it well. And she's just going to be talking a little bit about Karen Sparrow, who was an eye health professional who has been heavily involved in global health and has recently passed away. So a bit of a tribute to her. So Evelyn, I'm going to pass over to you. Are you able to, you've got a presentation, I think.
I do. Thank you, Sophie. I'll try. Does Claire need to stop
yes.
sharing her screen? And then I can start sharing. Great, thank you. I have to find the right thing though, don't I? Oh, hang on, sorry. Is that working?
It is.
Okay, but hang on, I have to do that, don't I? Right, there we go. So yes, as Sophie said, I was very lucky, and I was based in Botswana for about 4 years. And actually I met Claire because she was my next door neighbour. So I've known Claire we had been in Botswana about a year, and then Claire and her family moved next door. And so we became friends, and our children became friends. And obviously, because both Claire and her husband are doctors, we also worked together. And it's wonderful that we've continued to work together with the partnership that Cambridge has with Botswana across a number of areas. I'm just going to introduce you quickly to the Vision 2020 Eye Health link that we have had with Botswana since 2007. And then, as Sophie said, to talk about Karen Sparrow, who is oops, hang on, I didn't mean to do that, sorry. Talk about Karen Sparrow, but let me start off. So just to tell you a little bit about the Vision 2020 link. It was the first area of the partnership that we started when we established a link with Botswana in 2007. And it was really because the link came through two ophthalmologists, Malcolm Kamyo, who is an ophthalmologist based in Botswana, and Watokwa Nkomazana, who's an ophthalmologist from Botswana. And they met at the London School of Hygiene and Tropical Medicine when Watokwa came to do the Masters in Public Eye Health, and started to talk about the possibility of partnership. And here we are 15 years later, still in partnership, which is wonderful. And it's been a very broad partnership that's worked across a number of clinical areas in terms of eye health, but also involved some research and some education. It has been a little bit quiet over the last few years, but we're certainly hopeful that we will continue to grow that partnership. But I just wanted to talk particularly about Karen, who was an optometrist who first came to Botswana, I think in 2012, and she was an optometrist practicing in the UK and volunteered with a charity in the UK called Vision Aid Overseas. And we partnered with Vision Aid Overseas within our Seeing is Believing project called Pono Le Tlotlo, which was developing eye health services across Botswana, particularly focused on children's vision services and focused on developing refractive error and optometry services. So many people in Botswana who can't see well actually could see well if they had access to spectacles. And like Claire spoke about, one of the challenges in Botswana is the accessibility to healthcare services, including the provision of spectacles. So you tend to find that in the larger cities, there's access to spectacles, but it's all an optometry services, but most of it is private. And so for poorer parts of the population, it's very difficult for them to access glasses. And so Karen came and started to understand the situation. And then subsequently in our Seeing is Believing project, we focus particularly on establishing services so that vulnerable members of the population could access glasses. So Karen died at the beginning of January, having had a long battle with ovarian cancer. And I'll share the link in the chat later to some of the obituaries, but this was taken from the obituary from the International Agency for Prevention of Blindness, to say that global eye health has lost one of its kindest, most passionate advocates, and the world has lost a generous, selfless, and truly inspiring individual. And Karen really was extraordinary. I remember very well when she came to Botswana, how organized she was, how passionate and how thorough. She then worked with the team to establish a vision center that is still there in Sekgoma Hospital in Serowe. And it was chosen as a site because it was centrally located and would give access to more people. It's within the eye unit, the eye clinic at the hospital in Serowe. And there are optometrists and technicians there who can then make the glasses for people, and you pay a very small amount such that it has created a sustainable supply of spectacles. It has had challenges along the way, but there's Karen at the front, and Alice Lahassa, who's the National Eye Health Programme Coordinator, and then some of the staff. Mama Reki at the back was the optometrist at the time, and Claire was another eye health professional working on the project. And I just thought I'd tell you this story of a particular girl who accessed services through that vision centre. So Sandra was 17 when her grandmother had heard about this new vision centre in her community, and Sandra came to the vision centre, and she had had difficulties seeing for about 4 years since she was 13, but hadn't ever had an eye examination. And it was only when she came to the vision centre that she was able to have an eye examination. No one in her family wore spectacles, but she had had difficulty at school for a long time. But she said, I just took it quite lightly and sat at the front of the class. But she came, the optometrist tested her eyes, and then the technician, who's you can see there fitting the glasses on Sandra, made her spectacles and fitted them. And you can just see the delight in her face, and that I think that really nice photograph of her seeing herself wearing her spectacles. But when we asked her how did she feel that now that she'd had her eyes tested, she said, I will wear my new glasses proudly as I go to sit my European history final leaving exam, which was taking place in about an hour and a half after she received her spectacles. So I mean, that's just one individual that Karen's work impacted, but I know that there's many, many, many more. And Karen then went on to do the same master's degree at the London School that Watokwa had done, and then subsequently joined the Peak Vision team, who are working in Botswana also, and working with the Ministry of Health and Wellness to have a school screening program across the whole country. So Karen was also a fantastic team member. So that was us at the Sekoma Memorial Hospital when we visited the eye unit there. And just to finish with this, so Karen's family have asked us all to be more Karen and to live life to the full with kindness. So I just hope you, and I know that some of her colleagues from Peak as well are on this call. But yes, somebody who's been involved in the partnership who sadly is no longer with us. And I hope that maybe up there she'll have found Dr. Kermure, who was the ophthalmologist who was very involved in the partnership, and they'll be looking down and looking forward to seeing the continued development of eye health services and other health services. Malcolm was passionate about primary care, Claire, so he would absolutely share your sentiment.
Thank you, Evelyn. So I don't know if anyone has any thoughts or reflections on Evelyn's presentation, then please do just unmute or pop any thoughts in the chat box. Well, thank you. And you know, if anyone has anything that they want to share after the event, please do get in touch, and we can. I'm sure Fiona won't mind just popping our email address in the chat box, and yeah, please do get in touch. And just to say thank you very much to everybody who's joined us this evening. We run these events every couple of months, and we have a different theme each time, sometimes talking about our own partnerships, but also encouraging others who are involved in different areas of global health to join us. And as I said earlier, it's really inclusive. Please do come along, invite others to come along. And you can find out more on our website. which will also be able to pop in the chat box, bombarding you with information and links. And I think our next one is on the 5th of April, if I'm right, and that is going to be looking at global health in humanitarian context, so specifically Syria and Jordan, and that promises to be really, really interesting with some more fabulous speakers. So yes, I really hope you'll be able to join us then, and we'll send the link out for the next one to everyone who's attended this evening. And I've just spotted Poonam's added something lovely into the chat box, so I'll just read that out. So Poonam said, I had the pleasure of speaking to Karen on a one-to-one basis last year, and she was truly inspiring. She's further sparked my interest in global eye health, and I'll always be truly grateful to her. Thank you, Poonam. And what a lovely way to end. So thank you very much to everyone who's joined, and we hope we see you next time. Thank you.